So the next section is a particularly high yield section. So if you guys aren't having fun yet, time to start having some fun. So filtration fraction is something that is commonly tested on step 1. So let's spend a little bit of time talking about what the filtration fraction is. Well, it's a fraction. We learned about fractions back in 2nd grade. So this is just a fraction. So let's spend a little bit of time discussing this. Filtration fraction is equal to GFR over renal plasma flow. Filtration fraction is equal to GFR over renal plasma flow. The renal plasma flow is the volume of plasma that enters the kidneys every minute. That's the renal plasma flow. The renal plasma flow is the volume of plasma that flows into the kidneys every minute. That number is 600 milliliters of plasma. That's a number you should know. It turns out that we do not filter all of the plasma that flows into the kidneys. In fact, we only filter 20%. It's not a very big percentage, but that's how it works. We only filter 20% of the total renal plasma flow. And that's where the GFR of 120 milliliters per minute comes from. Normally, filtration fraction is only 20%. So the normal filtration fraction is 20%. We can adjust the filtration fraction, and that's what we're going to talk about on the next slide. Let's talk about the effect of vasoconstriction on the filtration fraction. You can vasoconstrict the afferent arterioles. If you vasoconstrict the afferent arterioles, what do you do to the GFR? You decrease it. If you vasoconstrict the afferent arterioles, remember, you're increasing resistance in a series circuit. Therefore, what are you doing to the renal plasma flow? Well, I can't see what you're saying, but I'm assuming that you're saying decrease. If you are, that's correct. You're decreasing. Now, if you're decreasing the GFR and you're decreasing the renal plasma flow, what are you doing to the filtration fraction? That's right. If you said nothing, that's correct. You are not changing the filtration fraction. The filtration fraction does not change if you vasoconstrict the afferent arteriole. Now let's go to the efferent arterioles. If you vasoconstrict the efferent arterioles, what do you do to the GFR? That's right, you increase the GFR. What do you do to the renal plasma flow? That's right, you decrease the renal plasma flow. The filtration fraction increases. So when you vasoconstrict the efferent arterioles, you increase the filtration fraction. That's an important concept. So this table summarizes what we just spoke about, vasoconstricting the afferent versus efferent arterioles. What I want to do now is really spend a minute talking about what the filtration fraction really means. Yes, it's a nice number to look at, but I really want to get into what this means to you for the exam and what this means to the kidneys. Think about what filtration fraction means. Filtration fraction really means the fraction of the renal plasma flow that's being filtered. So renal plasma flow at 600 milliliters. That's the volume of plasma that's entering the kidneys every minute. When you vasoconstrict the efferent arterioles, you increase the filtration fraction. So now, instead of filtering 120 milliliters, you are now filtering, let's say, for example, 200 milliliters. You just increase the volume of plasma that you're filtering. That's what increasing filtration fraction means. Now, who cares about that? Well, here's why you should care. Because the more plasma you filter, the more you increase the concentration of albumin. Because remember, when you filter, you leave albumin behind. You do not filter albumin. So if you filter more plasma, you leave behind albumin, you increase the concentration of albumin, and therefore you increase the what? You increase the oncotic pressure. So when you increase the filtration fraction, you increase the oncotic pressure. Now, who cares about that? Here's why you should care. Because that oncotic pressure now becomes the oncotic pressure of the peritubular capillaries. Okay? So if they give you a question and they say an agent was given that leads to an increase in the oncotic pressure as you're filtering, well, they can give you a graph. And the graph can show you the oncotic pressure increasing. And I've seen this in many questions. They'll give you a graph where they'll show you the oncotic pressure increasing after drug X was given. What did drug X do? Vasoconstrict the efferent arteriole. It increased the filtration fraction. Increasing the filtration fraction will increase the oncotic pressure. Now, that oncotic pressure will become the oncotic pressure in the peritubular capillaries, and that will lead to an increase in proximal tubular reabsorption. Now, what hormone will vasoconstrict the efferent arterioles? If you're saying angiotensin II, you are correct. Angiotensin II will vasoconstrict preferentially the efferent arterioles. So this is the effect of angiotensin II. Angiotensin II increases the filtration fraction. Sympathetic nervous system. So this is another high-yield topic that the examiners like to go after. In normal situations, in normal, restful, non-stressful situations, the kidneys auto-regulate blood flow. However, in a high-stress situation, autoregulation is removed and the sympathetic nervous system takes over. Let's discuss this. In a high-stress situation, sympathetic nervous system takes over. What happens? Increased sympathetic drive to the kidneys causes vasoconstriction of both afferent and efferent arterioles. I'll say it again, both afferent and efferent arterioles, but the greater effect is the afferent arterioles. That will lead to a decrease in renal plasma flow. That will lead to a decrease in GFR. GFR will decrease. This will lead to an increase in filtration fraction. This will lead to an increase in oncotic pressure. One other important thing that the sympathetic nervous system has is an increase in renin secretion. The juxtaglomerular cells, known as the JG cells, are specialized cells of the afferent arterioles that secrete renin. In response to increased sympathetic drive to the kidneys, they contain beta-1 receptors, and when you increase sympathetic drive to the kidneys, they increase renin secretion. Here's a high-yield point. Beta blockers decrease renin secretion because beta blockers block beta-1 receptors in the kidneys, and they blunt the sympathetic response. That's something that examiners love to go after. Beta blockers reduce renin secretion. Beta blockers decrease afterload on the heart by inhibiting renin secretion because renin leads to angiotensin II. Angiotensin II vasoconstricts your peripheral arterioles. Vasoconstricting the peripheral arterioles increases afterload on the heart. So beta blockers reduce afterload on the heart by inhibiting renin secretion. That's a high-yield point that they like to ask you on the exam. Okay, so let's go back to filtration fraction. When you increase sympathetic drive to the kidneys, you vasoconstrict both afferent and efferent arterioles. So let's take a look at what happens here. GFR has to decrease. Why? Because you're vasoconstricting the afferent arterioles. So GFR has to decrease. Bottom line. However, because you are vasoconstricting both afferent and the efferent arterioles together, you will have a larger drop in the renal plasma flow. So you will have a disproportional decrease in the renal plasma flow because you're vasoconstricting both afferent and efferent arterioles. Because the renal plasma flow is dropping more than the GFR is dropping, that will actually lead to an increase in the filtration fraction. This is why the filtration fraction increases when there's an increase in sympathetic drive to the kidneys. Now, we said before, increase in filtration fraction will lead to an increase in oncotic pressure because you filter more plasma, leave behind more albumin, oncotic pressure increases. They like to go after that. And that will lead to an increase in proximal tubule reabsorption of fluid and solutes. So, the overall effect of increase in sympathetic drive is to decrease GFR. You filter less, but you increase filtration fraction, and you reabsorb more. This is how the kidneys preserve volume in a low volume state. Angiotensin II. Let's straighten out angiotensin II. Very potent vasoconstrictor. Powerful vasoconstrictor. Vasoconstricts everywhere in the body. In the peripheries. Increases TPR. Increases afterload. Okay? It does vasoconstrict both afferent and efferent, but mostly efferent arterioles. What's the major effect of angiotensin II? Well, it does decrease renal plasma flow, but it increases GFR. Why does it increase GFR? Because its main effect is on the efferent arterioles. Therefore, it increases glomerular capillary hydrostatic pressure, and that increases GFR. It increases filtration fraction. That's important. And that leads to an increase in your oncotic pressures, and that leads to an increase in proximal tubule reabsorption. Now, what angiotensin II does is really cool. Here's why it's cool. Angiotensin II is secreted in a low volume state. And angiotensin II preserves GFR in a low volume state. It allows you to maintain GFR in a low volume state without losing volume. Here's how it works. By increasing, very important, increasing filtration fraction. It allows you to maintain the GFR, so you maintain filtering. Why do you want to maintain filtering? Well, you still want to filter your toxins. You still want to filter urea, creatinine, uric acid. You still want to get rid of the bad stuff, but you want to keep the good stuff. What's the good stuff? Volume, solutes. So you still filter out the toxins, but by increasing the filtration fraction, you increase the oncotic pressure. So when this oncotic pressure wraps around to become the peritubular capillary oncotic pressure, you increase the reabsorption. So you reabsorb the fluid that you filter. So what angiotensin II allows you to do by increasing filtration fraction is it maintains GFR without losing volume. So you've maintained filtration, and then you reabsorb the volume that you filter, so you do not lose any volume. And that's what angiotensin II does by increasing filtration fraction. How cool is that? I challenge you to find something cooler than that. I bet you can't do it. Go ahead, good luck. Okay, so let's summarize the stress response. Step 1 will give you a patient who's hemorrhaging, or a patient who has profuse diarrhea or vomiting, or a patient who's lost in the desert and has lost their bottle of water and is severely dehydrated. And they will ask you, what's going on? Well, we went over what's going on. This is the summarization. Filtration fraction goes up, GFR drops, small drop in GFR, large drop in renal plasma flow, filtration fraction goes up, increase in proximal tubule reabsorption. That's the summary of a stress response. This is the question it'll ask you. This is a high yield topic. Let's talk about renin release. This is another high yield topic. What can cause renin release? Where does renin come from? Why do we secrete renin? 3 reasons. 1, 2, 3. Let's talk about this because they love to ask you this. Renin comes from specialized cells in the afferent arterioles, the juxtaglomerular cells, or we call them JG cells. 3 things. Decreased flow in the afferent arterioles will stimulate renin release. Clinical examples: hemorrhaging, severe dehydration due to diarrhea, vomiting, being lost in the desert. Low flow states like CHF. Patients with CHF have high renin secretion. Very commonly tested. In patients with CHF, they have high renin secretion. Renal artery stenosis, another high yield topic. In renal artery stenosis, they have high renin secretion because renal artery stenosis leads to low flow in the afferent arterioles, and that will stimulate renin release. That's another high yield topic. Increased sympathetic drive. We just went over that. Increased sympathetic drive. These cells have beta-1 receptors. Increased sympathetic drive will directly stimulate renin release. That's another important one. Number 3, this is where students universally get confused. So let's spend a minute on this. Students always get this one wrong. So you are going to get it right. What is the macula densa? The macula densa is the portion of the nephron where the thick ascending loop of Henle meets the early distal convoluted tubules. It is part of the nephron, the very same nephron that is filtering. It's the same nephron. This is part of what we call the juxtaglomerular apparatus. It's right next to the JG cells. They touch each other. They hug each other. They're adjacent to each other. When you're in a dehydrated state, GFR decreases, reabsorption in the proximal tubules increase. So because there's an increase in reabsorption in the proximal tubules, the luminal fluid of that very same nephron has a low concentration of sodium chloride. So the luminal concentration of sodium chloride, I'm talking about in the ultrafiltrate, and here's where I want to be clear. I'm not talking about sodium chloride concentration in the plasma. I'm talking about the sodium chloride concentration in the ultrafiltrate that was filtered at the glomeruli, that is inside the nephron, not the plasma, the ultrafiltrate that was formed at Bowman space in the nephron, not the plasma. I want to be very clear on this. So in a dehydrated state, we said the GFR drops, there's an increase in reabsorption at the proximal tubules. So that nephron in a dehydrated state will have low luminal concentration of sodium chloride. The macula densa has sensors for this. When the macula densa senses low luminal concentration of sodium chloride, that's a signal to say, hey, we are in a dehydrated state. We better secrete renin. Renin secreted in high stress states, low volume states. Low luminal concentration of sodium chloride is a signal that you're in a low volume state, and that tells the macula densa to secrete renin. So number 3 is high yield, and a lot of students get that confused. It is low luminal concentration of sodium chloride at the macula densa that stimulates renin release. Very important to understand that. This is the ultrafiltrate, not the plasma. Okay, let's spend a few minutes on ACE inhibitors and angiotensin II receptor blockers. These drugs are very commonly used, and let's spend a minute on them. So we use them to treat diabetic nephropathy. Why do we use them, and how are they helpful? Well, they lead to reduction in glomerular capillary hydrostatic pressures because they inhibit the effect of angiotensin II, which leads to vasodilation of the efferent arterioles, and that leads to a decrease in GFR. Now you might be saying, wait a minute, why in the world would you want to decrease GFR? Isn't GFR a good thing? Well, remember, I mentioned before the pathophysiology of diabetic nephropathy. I said these patients get hyaline arteriolosclerosis of the efferent arterioles, leading to hyperfiltration of the glomeruli, and that hyperfiltration leads to glomerular sclerosis. So we actually want to reduce the hyperfiltration pressure. So the ACE inhibitors and ARBs, by vasodilating the efferent arterioles, by inhibiting angiotensin II, they reduce these hyperfiltration pressures. This is a concept known as glomerular hypertension. ACE inhibitors and ARBs, they treat the glomerular hypertension, they reduce these hyperfiltration pressures, and they reduce damage and fibrosis of the glomeruli. And clinical trials show that they delay the need for hemodialysis. So these are very commonly used. This is the management for diabetic nephropathy, ACE inhibitors and ARBs. We also use them in any patient with nephrotic syndrome for the same idea. So anybody with nephrotic syndrome should be on ACE inhibitors or ARBs. So again, we give these agents to anybody with nephrotic syndrome with stable chronic renal failure. We do avoid them in patients with severely compromised GFR because they can get hyperkalemia. We'll discuss that later. And we do not give them in patients with acute renal failure because when patients have acute renal failure, we want to give the kidneys time to recover. ACE inhibitors and ARBs may cause a type 4 renal tubular acidosis because they block aldosterone, leading to hyperkalemia. We'll get to this in the later section. If ACE inhibitors cause a cough or angioedema, we can replace the ACE inhibitor with an angiotensin II receptor blocker. ACE inhibitors and ARBs are contraindicated in bilateral renal artery stenosis. So this is a classic exam question I'd like to ask you. If you give a patient an ACE inhibitor or an ARB, and they have a rapid decrease in GFR, the answer is they have bilateral renal artery stenosis. In patients with bilateral renal artery stenosis, because both arteries are stenosed, they have decreased renal perfusion, decreased renal blood flow, and both kidneys have a decrease in GFR. Well, both kidneys have an increase in renin release, and angiotensin II is vasoconstricting the efferent arterioles in both kidneys, and that's maintaining GFR. Those kidneys are actually highly dependent on angiotensin II to maintain the GFR. By giving these agents and taking away the effective angiotensin II, you're going to get a very rapid decrease in GFR, and that's why they're contraindicated in these patients. ACE inhibitors can cause angioedema because they lead to an increase in levels of bradykinin. Bradykinin vasodilates the arterioles. Vasodilating arterioles leads to increase in blood flow to the capillaries. Bradykinin, in addition, also increases capillary permeability. Increase in capillary permeability will lead to edema formation. So this is the pathophysiology of ACE inhibitors leading to angioedema. There is an increased risk of ACE inhibitors causing angioedema in patients with hereditary angioedema. This is a disorder where patients have a C1 esterase inhibitor deficiency. C1 esterase inhibitor inhibits production of bradykinin. So in patients with C1 esterase inhibitor deficiency, ACE inhibitors are contraindicated because there's a very high risk of angioedema. I want to spend a minute now talking about the role of prostaglandins in the kidneys. The very same stimuli that induce a stress response in the kidneys, that stimulates sympathetic drive, will induce a local release of prostaglandins. Prostaglandins cause vasodilation of the afferent arterioles. So in a stress response, you have the sympathetic nervous system vasoconstricting the afferent arterioles, and you have the prostaglandins vasodilating the afferent arterioles. Wait a second, you're thinking, that's crazy. Are you constricting? Are you dilating? You're driving me crazy here. Well, yes, I am a little crazy, but here's how it works. The purpose of the prostaglandins are to keep the sympathetic nervous system in check, to prevent the sympathetic nervous system from having too much vasoconstriction, to have an extreme drop in GFR and renal plasma flow. That's the purpose of prostaglandins, to prevent a severe drop in renal plasma flow and GFR. You want to drop the GFR to some extent, but you don't want to drop it too much. You still want to have some filtration. You don't want to stop filtration completely, and that's the role of prostaglandins. So let me give you a clinical correlation. Let's say somebody's hemorrhaging and they're in an increased sympathetic state. Sympathetic drive, vasoconstricting the afferent arterioles. One drug you would want to avoid in this patient is NSAIDs. NSAIDs will block production of prostaglandins. That would lead to unopposed vasoconstriction of the afferent arterioles, and that would lead to an acute, intense drop in GFR and renal plasma flow, and that could cause acute tubular necrosis. So this is why NSAIDs should be avoided in this patient.